We shall now go on to our next talk, leaving the controversies afloat. We have Dr. Harshavardhan, who's again a consultant cornea, refractive and cataract surgeon from Fortis Hospital, Vasi, Mumbai. And he's going to talk on a very relevant topic, various indications and application techniques for amniotic membrane grafting. On to you, Dr. Harshavardhan.
Yeah. Hello, everyone. A completely different topic from the previous one, amniotic membrane transplantation. At the outset, I would like to thank AIOS and ARC for this opportunity, especially Chitra madam. There are no financial disclosures. The global amniotic product market is going to reach to $1 billion by 2026 at a rate of 8.2% per year. And it is mainly powered by surgical wound repair and the ever increasing indications in ophthalmology. We all know it started with Dr. Davis with skin transplantation in 1910, and then by Dr. D. Roth for conjunctival reconstruction, and later revived by Dr. Seng et al. After Yuan Battle's report for stem cell therapy. It forms part of the fetal membrane. The inner one is amnion, outer chorion, and it has 5 layers: cuboidal epithelium, basement membrane. Stroma has compact layer, fibroblast layer, and spongy layer. It has important properties like anti-inflammatory, anti-fibrotic, epithelial proliferation, differentiation, adhesion, antimicrobial, anti-angiogenic, and analgesic, and it is non-immunogenic. In addition, it is a source of stem cells. It is a biological, biocompatible scaffold and an anatomical barrier allowing gas exchange. In short, it is easily available, translucent, non-immunogenic, but it is a biological membrane and non-standardized, and tectonically not very strong and can transmit infections. The alternatives to amniotic membrane are conjunctiva, fascia, mucous membrane, pericardium, and Tenon's capsule. It is procured by separation from the chorion, placed on nitrocellulose paper, cut into 4 by 4 centimeter strips. Each amnion can give about 30 strips. It is then preserved in modified Eagle's medium with glycerol and stored at -80 degrees by cryopreservation. There are other techniques of preparation preservation like freeze drying, heat drying, and the donor is screened for blood-borne diseases. This is how we separate the amnion from the chorion before it is cut into pieces. This paper says that there is a change in the properties of the membrane based on the type of preparation and preservation. This could be the membrane could become thin, friable, papery, or thick and uniform, and also the transparency can be affected. In addition, the biological properties can get affected because of these preparation techniques, and it has been found that the augmented dried membrane is much more superior to the cryopreserved membrane. In short, today we have amniotic membrane in the form of stem cells as fresh, frozen, dried, decellularized, micronized, amniotic membrane powder, scaffold, amniotic membrane drops, fillers, and all sorts of things for treatment. And non-ophthalmologically, it can be used for treating skin burns, diabetic and venous ulcers, abdominal hernias, vaginal repairs, closure of pericardium, and a barrier to prevent surgical adhesions. In ophthalmology, non-commercially, it is used as a fresh membrane after delivery or as a cryopreserved membrane, as was described before. And it can also be used in ICU settings around IV tubing or a conformer or with glue, and with Amcerter ring, which was recently innovated by Dr. Bhaskar. Commercially, it is available as Procera, which is a cryopreserved with a soft contact lens conformer ring, freeze-dried as Visioamtrix, heat-dried as Ambiodis, and Omnigen, which is vacuum-dried with Trehalose and is supposed to have better biological properties. These are the various membranes: Procera, the Amcerter, and the Omnigen on the right. Procera is more popular. It is available as Procera Slim, Procera Classic, and Procera Plus. The more severe is the indication, the more thicker the Procera we use. This is how it is inserted, first in the upper eyelid, and then we pull the lower eyelid and place it inside. So coming to the ophthalmic uses, the amniotic membrane is basically used as a substrate for growth of epithelial cells, as a tectonic support for perforation and thinning, as a replacement to cover large corneal and conjunctival defects, and to reduce inflammation, fibrosis, angiogenesis, and infection. So what are the various techniques of transplants? So there are 3 major techniques: inlay, which is either single layered or multi-layered, onlay or overlay, and combinatorial or a sandwich technique. In inlay, the basic thing is that the diseased tissue is removed and the amniotic membrane replaces the diseased tissue with the basement membrane facing upwards. So what happens is that the host epithelium now grows on this basement membrane. The disease, the amniotic membrane becomes part or gets remodeled into the host tissue, and therefore it gives it tensile strength. If the defect is deep, we use multiple pieces of membrane over each other and then finally put a single membrane. In this technique, the entire membrane is sutured within the defect with the help of 10-0 ethylene radial sutures. The second is onlay, which is like a patch. It is used as a biological dressing basically, and the membrane is placed with the epithelium facing down. It basically covers the defect. It doesn't become part of the host tissue. It falls off after 7 to 10 days or has to be removed, and it gives good anti-inflammatory, anti-fibrotic, and mechanical protection. In this, the membrane is sutured around the epithelial defect with 10-0 ethylene per string sutures. And the third one is a combination technique. We use the advantages of both. The inlay is used to allow the epithelium to grow and provide tectonic strength, while the onlay covers the growing epithelium and provides it protection. The example being the ACER technique described by Professor Dua, who was also my mentor long back. And the main difference, how to identify the stromal side, is by using cotton buds or a small forceps, and we can get sticky vitreous like strands coming on the stromal side, or we can even stain them with trypan blue or lissamine green. So what are the indications based on the various parts of the eye? In cornea, it can be used to treat persistent epithelial defects, ulcers, thinning, perforations, epithelial lesions like recurrent corneal erosion, scars, Salzmann nodular degeneration, and tumors. It can be used as a pressure patch to prevent epithelial ingrowth. It can be used for painful bullous keratopathy, limbal stem cell deficiency. We can do stem cell transplant, and bacterial and herpetic keratitis can be treated with this. Conjunctiva, it can be used to reconstruct ocular surface after removal of conjunctival tumors, scars, treating symblepharon, after pterygium surgery as a replacement for conjunctiva in case we don't have adequate conjunctiva, and in conjunctival collasis. As an anti-inflammatory, it can be used in acute chemical burns, thermal burns, acute Stevens-Johnson syndrome, PUK, dry eye, and PRK, post-PRK. In oculoplastics, it is used for anophthalmia and socket reconstruction, phonics formation in OCP and SJS, covering of orbital implants, entropion and eyelid repair, post-tumor removal, corneal patch to protect against radioactive plaques, and in cryptophthalmos repair. In glaucoma, it can be used for bleb revision, overfiltering blebs, leaking blebs, filtering under the, it can be used under the scleral flap to reduce fibrosis, and as a patch graft during to cover drainage devices. And in miscellaneous, it can be used to as a substrate for ex vivo expansion of limbal and mesenchymal stem cells, in strabismus surgery to reduce the fibrosis around the muscles, and in retinal surgery also it is being used for macular hole and retinal tear plugging. So in most of the indications, we use the inlay grafts. So basically the corneal, conjunctival, and even the glaucoma oculoplastic indications, we employ the inlay graft. The onlay graft is basically used for acute chemical burns in the first 7 days to reduce the inflammation and give pain relief to the patient. In cicatrizing conjunctivitis in acute SJS, it is used to reduce the corneal haze, and formation of symblepharon have been reduced according to studies. And in dry eye disease, it is used as a level 4 intervention.
You have 1 minute remaining,
as per DUS protocol, and in recurrent corneal erosions. In a combination, it is used as limbal stem cell transplantation. It can be used for perforations, shields, ulcer, and in chemical burns. Complications include hematoma under the membrane, subepithelial membrane which is retained causing opacification, premature degradation of the membrane, microbial infections, calcification, white plaques, and inconsistent results because of lack of standardization. So these are the various examples. In Stevens-Johnson, we cover the entire ocular surface along with the skin. In perforations, we use a sandwich technique. Sorry, not a sandwich technique. The combination technique where gas is also injected in the anterior chamber to plug the perforation. In pterygium, we replace the conjunctiva and the epithelium then grows over it. Here the Procera is being used to treat herpetic keratitis. Here Omnigen is being used to treat neurotrophic keratitis. This is a case where we used the sandwich technique to treat limbal stem cell deficiency. The first membrane was the inlay, which was secured with glue, which formed part of the corneal stroma. The stem cells, the explants were placed by the slit technique, and then we placed the onlay graft, which acts like a protection, and the stem cells grow inside like as if growing in an incubator. And this is what we get, opaque cornea clearing up to 6/6 vision 5 years down the line. This is another case of grade 6 chemical burns with skin involvement. Here we use it as an onlay in the first 7 days. It helped to reduce the inflammation. It helped to reduce the symptoms of the patient. Purse string sutures being applied, and the excessive membrane is then used to cover the skin lesions, which are also there in this case. So these are the advances. We have ultra thin amniotic membranes available today, which help in epithelial growth in a better way and also give transparency to the cornea. These are photo cross-linkable amniotic membrane hydrogels, which give good tectonic support, and they have been used in surgical indications. And this is nanofiber reinforced decellularized membrane and a synthetic polymer amniotic membrane, which helps the limbal stem cells to grow better because they are retained well. The membrane is retained well in the eye, and the stem cells can grow. So in short, it is a very good innovation to reduce inflammation, promote healing, give symptomatic relief, good alternative to conjunctiva, mucous membrane, non-allogenic, easily available. However, it has variable properties, can give inconsistent results, can be stored up to 2 years, can transmit diseases, can be used sutureless in emergency and clinic settings, can be used inlay, onlay, or both. Non-commercially available as fresh, frozen, commercially as dried and augmented with superior biological properties, and the recent advances have enhanced its properties and applications. These are the references. Thank you very much.
Thank you very much, Dr. HARSHAVARDHAN. That was a lovely talk. We'll just take one question because we are running short of time. In a persistent epithelial defect, when would you think of using an AMG, or when would you think of doing a tarsorrhaphy, or when would you think of using serum drops? Dr. Radhika, would you want to answer that?
I will. Thank you. It's a very pertinent question. And, one will have to do a stepwise approach. First, try to find out the cause for the persistent epithelial defect and look at any associated factors like if there are any trichytic lashes, dry eye, etc. And personally, I feel that if it's a neurotrophic ulcer, one can first try autologous serum drops. If you have confocal microscopy and you find that there is an activation of the keratocytes, or if you find that the nerve fibers are showing features of inflammation, then autologous serum drops is a good way to start. However, if it's a completely neurotrophic cornea with hardly any keratocytes, then one may have to go for AMG straight away. And autologous serum, you usually will give it a trial of about a week or two. By then you'll come to know if there is any effect appearing or not. And if there's absolutely no change, then you can go ahead with the next step of an amniotic membrane. So they do complement each other. It's after all, amniotic membrane, as he said, it is a surgical procedure, and it is always having that slight, very, very rare risk of infection transmission, which you cannot ignore. So if you can give autologous serum therapy and it works, it's always what you would like to do first.
We also go one step ahead at times to do neurotization in such cases after amniotic membrane fails. So I had just one question about this case. We had thermal injury, firecracker. One eye is already gone. There is an implant placed there. This is the only eye which is seeing 1 meter. There is pannus growing superiorly. The lower part of the cornea appears clear, through which the patient is able to see something, and the central cornea shows scarring. My question is whether just removing the pannus, placing an amniotic membrane would be better, or taking stem cells from the inferior part and doing a slit would be better, or taking stem cells from his...
Should we take this question after the next talk, which is going to be on slit and optimizing outcomes? So we'll take this, definitely we'll take this example at that time.
Okay.
Yeah, and Vikas will answer the question because
Vikas will answer this question. He's going to give that talk. Yeah.
Okay, sure.
So we look forward. This was a wonderful talk, Dr. Harsh.